We all know what exactly this particular condition is. Day in, day out, we see this sort of a picture here in our general surgical practice. We see so many patients who come to us with non-specific abdominal pain. Then we do an ultrasound, and that ultrasound will pick up some sort of a hydronephrosis. It may be just a dilatation of the pelvic calyceal system, which we call as a hydronephrosis, or there may be an associated dilatation of the ureter also, which is called as a hydroureteronephrosis. And this condition is something which we very commonly come across in our general surgical practice. The reason why we talk about this particular topic, obstructive uropathy, is because if we are able to diagnose this condition at the level of hydronephrosis or hydroureteronephrosis before it becomes an obstructive uropathy, the chances of recovery is maximal here. And that's the reason why we are, the next 20-25 minutes or half an hour, I'll be talking about what an obstructive uropathy is all about. Why is it important for one general surgeon to know about obstructive uropathy? It's because there is always a considerable overlap between what the general surgeon sees in general practice and what the urologist sees. About 30 to 40% of the cases that a general surgeon sees in their regular practice will have some sort of a urological connect, something at least. Some sort, the patients, elderly patients, will have symptoms related to prostate. The younger individuals will have some symptoms related to stone disease or congenital hydronephrosis due to various reasons. Those will present to the general surgeon as non-specific abdominal pain. It's very important for the general surgeon to identify these conditions a little early before they inflict some sort of a damage which may be reversible or an irreversible damage to the kidneys. Before that, the general surgeon has to identify these conditions and treat them appropriately. Most of the times we get referrals from general surgery for stone diseases. So these patients go to the general surgeon as an acute abdomen with right iliac fossa pain, right groin pain, right loin pain, right hypochondrium pain, which are being referred from the emergency room to the general surgeon. General surgeon does an ultrasound or a CT, and then they make a diagnosis of a ureteric stone, and then the urologist is called. In a tertiary care center like Ramachandra, where we have a 24/7 urology service available, there should not be any issue at all. But this luxury is not available in most of the centers. In many district headquarters hospitals, where we have only the DAS available, the duty assistant surgeon available, who will be manning the entire hospital after 1 o'clock or 2 o'clock in the afternoon, the entire load will actually fall on the surgeon. The surgeon has to deal with all the surgical emergencies, all the urological emergencies, including the cardiothoracic and the neurosurgical emergencies. Sometimes in some district headquarters hospitals, it happens like that. So it's very important for the general surgeon to know what exactly these urological conditions are. Make a diagnosis early and try to treat them, or at least they should know what exactly the algorithm for treatment should be like. What will be the checklist, next 1, 2, 3 level of interventions are, so that the urologist can be called immediately or as early as possible, so that the patient gets benefited. The other reason why a general surgeon should know about obstructive uropathy is that the morbidity associated with the obstruction of the urinary symptom is so huge and sometimes so irreversible that it can cause some sort of a catastrophic effect or impact on the ultimate patient's life, or at least on the kidney. Obstructive uropathy is one condition where the patient's urinary tract gets obstructed, as a result of which the morbidity increases because of either obstruction or because of kidney damage or because of urosepsis or because of septicemia, where there is a dissemination of the urinary tract infection into the bloodstream, and that causes some sort of a disseminated septicemia, which can ultimately lead on to multi-organ dysfunction as well. So these are all the issues that we'll have to take into consideration whenever we see such patients, and especially since the general surgeon is the first level physician who sees these patients, it's very important for the general surgeon to know about this particular condition, so that timely detection and appropriate intervention can be life-saving. The third reason why a general surgeon should know about this obstructive uropathy is because most of the times this obstructive uropathy occurs in acute settings. These patients come to the casualty. If the patient comes to the OPD, they can always have another urologist available in the OPD timing. They can be referred to that particular specialist. On the other hand, if this patient comes to the emergency room, say at midnight, if the patient comes either with ureteric colic or with fever, chills, and rigor, where there are signs of urosepsis or gram-negative septicemia, or for example, a simple urinary retention secondary to prostate enlargement, These are very frequently the conditions which we come across in our clinical practice. I'm sure all of you would have gone through all these, seen all these cases in your emergency room as the duty postgraduate or as a junior consultant. I'm sure you would have seen all these cases where you would have come across patients with retention. Unless you examine the patient, unless you know what exactly the retention of urine is all about, the patient will usually complain of lower abdominal discomfort, not passing urine. A simple placing hand on the patient's lower abdomen will give you the diagnosis. So it's very important for you to know. If in case this goes undiagnosed, if the patient is in retention of urine, that will cause, if the patient develops a chronic retention of urine, sometimes what will happen, over a distant bladder will become painless. Such painless chronic retentions of urine will cause back pressure effect on the kidneys, and these patients can sometimes present later on to the urologist with obstructive uropathy. That's what we are going to talk about in the next 20-25 minutes. So what do we talk about? First, we will define what exactly this obstructive uropathy is all about. And then the most important thing is distinguish an obstructive uropathy from a nephropathy. I'll tell you the differences between what an obstructive uropathy and obstructive nephropathy are, why that is important, that you will know at the end of your session, and then classify the various types of obstructive uropathy based on the level of obstruction or the chronicity of the obstruction or the severity with which the patient presents to you with, and the pathophysiology and the diagnostic algorithms, and what exactly you should do when a patient comes to you with this sort of a symptom or condition. So, what exactly is an obstructive uropathy? Obstructive uropathy is, by definition, it is passage of urine from the kidney to the exterior is blocked somewhere. That is obstructive uropathy. It's a very, very broader way of defining obstructive uropathy. Any obstruction to the urinary system is obstructive uropathy. But again, another condition that you may have to probably understand is hydronephrosis. So, what is the difference between a hydronephrosis and obstructive uropathy? Mere dilatation of the pelvis, renal pelvis, or the collecting system, or the ureter because of an obstruction is called as a hydronephrosis or hydroureter nephrosis. It's a simple, broader terminology where we only talk about the dilatation of the pelvic calyceal system. That is called hydronephrosis. On the other hand, what is obstructive uropathy? An obstructive uropathy is one where there is not only dilatation, but also there is an abnormality of the renal parameters. If you look at the serum creatinine levels, it will be elevated. If you look at the blood urea, that will be elevated. If you look at the electrolyte, that may be there may be hyponatremia, there may be hyperkalemia. All these are the other metabolic acidosis. All these are the other associated features, signs, biochemical abnormalities that you will see in a patient with obstructive uropathy. Whereas hydronephrosis, if you say, that does not talk about any of these biochemical or electrolyte abnormalities. Hydronephrosis means there's a mere dilatation of the pelvic calyceal system or the ureter. That's called hydronephrosis or hydroureter nephrosis. On the other hand, obstructive uropathy is one where, in addition to hydronephrosis or hydroureter nephrosis, there is also an associated biochemical abnormality or an electrolyte abnormality. That distinction you should be able to make between hydronephrosis and obstructive uropathy. There's another terminology called an obstructive nephropathy. The learning objectives I was mentioning, it's very important for you to distinguish between what an obstructive uropathy is and what an obstructive nephropathy is, because you would like to, as a treating physician, you would like to retain the patient at the level of obstructive uropathy. You don't want the patient to develop an obstructive nephropathy, because obstructive nephropathy is a much more serious, much more dangerous end point where the patients will have some sort of damage to the kidney, or there will be some sort of a dysfunction of the glomeruli taking place. On the other hand, if you look at obstructive uropathy, the obstructive uropathy, there is only a structural obstruction or a functional interruption to the urine flow. That is all the obstructive uropathy will cause. If you look at the obstructive nephropathy, there is a permanent damage to the glomeruli also. Glomerular dysfunction is characteristic of obstructive nephropathy. The reason why you want to distinguish the two is because in obstructive urea, both will have an elevated serum creatinine. If you look at the serum creatinine, if you look at the blood urea levels, both will show an elevated levels of or abnormal biochemical findings. On the other hand, if you relieve obstruction in obstructive uropathy, the biochemical abnormalities are reversible. Whereas in obstructive nephropathy, there is already a glomerular dysfunction which has taken place. This obstruction, relief of obstruction, will not cause normalization of the renal parameter. So that is the distinction that you'll have to make, because obstructive, once the patient develops an obstructive nephropathy, it becomes an irreversible damage. Whereas if it is an obstructive uropathy, the obstruction and the biochemical abnormalities are still, once the obstruction is relieved, the biochemical abnormalities are reversed. So it's very important for you to identify these patients at the level of obstructive uropathy, treat them before they enter into the phase of obstructive nephropathy so that the glomerular damage can be minimized. So that's the whole purpose of this particular topic. Okay, so it's very important for you to identify these individuals and either treat them by yourself or at least call for help from the urologist or refer the patient to another center where the urology service is available so that the obstruction is relieved. If it is simple retention of urine causing obstructive uropathy, putting a catheter by yourself can solve lots of issues for the time being at least. Patient can undergo a prostate surgery on a later date, but at least the relief of obstruction in the form of placing a ureter Foley catheter can actually solve most of the problems. So that at least you should be able to do. And if you look at the overall incidence of obstructive uropathy, it's not a very uncommon disease. It's something which we commonly come across on a day-to-day practice. In our institution, every day we come across at least 2 or 3 such patients in our OPD and in our ER. These patients may need a stenting, these patients may not need a stenting, these patients may need an external diversion in the form of percutaneous nephrostomy or may not need, but whatever it is, patients with obstructive uropathy, especially the diabetics, these diabetics with uncontrolled sugars, they develop a condition what is called as a renal papillary necrosis. So this necrosed papilla can sometimes slough out from the kidney. They can fall down into the renal pelvis and they can track down into the ureter and may obstruct the ureter, producing a situation which is an emergency situation. That is what we call as an infected hydroureter nephrosis or sometimes an obstructive uropathy if the creatinine levels are deranged. So this is a very very common condition that we come across in our center. Ramchandra sees most of these cases, and we have got one of the largest publications of patients with acute pyelonephritis. We've got patients largest series of or collection of cases with emphysematous pyelonephritis, another dreaded condition which we commonly come across, which can also come under this obstructive uropathy complex, we call it. So these patients with acute pyelonephritis, these patients with emphysematous pylon, where there is a gas-producing organism which will infect the kidney, and the kidney parenchyma will appear a little frothy. There will be air pockets within the parenchyma, and that will cause a destruction of the parenchyma. Prompt identification of such conditions is very very important, and once we make a diagnosis, we relieve the obstruction either by an internal diversion with a double J stent or an external diversion with percutaneous nephrostomy or a PCD, percutaneous drainage of the collection, perinephric collection. If at all there is anything, then that can be done to relieve the obstruction so that the patients will not go into the phase of an obstructive nephropathy. It's very important for you to retain the patient at the obstructive uropathy level itself. It's very, very common in countries with the lower socioeconomic status, where there are so many barriers. Educational literacy barrier is there, accessibility barrier is there, and affordability barrier is there. These are all the factors which will delay the presentation to the hospital. Patients may not be literate enough to know what exactly is happening, but they'll be thinking that it's just a fever that they are dealing with, and somebody will say it's just a viral fever which will go off in about 4 to 5 days, self-limiting, and then the patient will come to you in the stage of irreversibility or in the stage of florid sepsis. So it's not very uncommon to see such conditions in our Indian scenario, and patients also present very late because accessibility is again another issue. If this happens in a remote village, access to the main center is again not so easy. And diabetes is very very common in our country. It's very prevalent in our country, and diabetics with immunocompromised status developing gas forming organisms and emphysematous pyelonephritis is not very uncommon to see, okay, in our setup. I mentioned earlier, we can classify obstructive uropathy based on the level of obstruction. It may be at the pelvis or the pelviureteric junction, which is called as a PUJ obstruction, which is a congenital condition where there is an aperistaltic segment at the level of pelviureteric junction, which can cause a functional obstruction. So obstruction can be at the level of upper tract or the lower tract. Lower tract includes a bladder. There may be a big mass in the bladder. There may be a stone in the bladder which can block. There may be a big transitional cell carcinoma or a squamous cell carcinoma, which can be a large mass which can block either the ureter and produce obstruction, or it can block the bladder, neck, and produce retention of urine. So all this unstructured urethra is again another common condition that we come across in our clinical practice. So these can all produce either upper tract level or lower tract level of obstructive uropathy. It may be unilateral or bilateral, and depending on the chronicity, it can be an acute presentation or a chronic pyelonephritis with infected hydrouretronephrosis presenting as obstructive uropathy. The obstructions that we talk about may be a complete one or maybe a partial obstruction, where further imaging in the form of a nuclear imaging with a DTPS scan can actually tell us the degree of obstruction also. And the etiology, based on whether it is present at birth or not, we can classify them as congenital or an acquired type of obstructive uropathy. Again, there's another diagrammatic illustration. We can have obstructions at the level of intrarenal. The obstruction may be either intrarenal or it may be postrenal or from within the bladder or post-vesical. Post-vesical means either the bladder neck. The prostate enlargement is the one which we commonly come across, a BPH or a CA prostate, or further lower down the urethra there may be a stricture, there may be a diverticulum, or there may be a BXO, balanitis xerotica obliterans, or lichen sclerosis heterotrophicus of the meatus, which can produce a BXO and meatal stenosis. All these are the other conditions which can also, all these are the conditions which can produce an obstructive uropathy. The common ones that we come across are stone diseases. These patients classically present with loin pain or loin to groin radiation of pain, which is the most common emergency condition that we come across in our general surgical practice. These patients usually will go to the general surgeon as being referred from a general practitioner as appendicitis. It may be presenting a right hypochondria pain, loin pain. A general practitioner may not be able to differentiate between loin pain and a hypochondria pain. Patient may also have a small gallstone. They may be referred to a general surgeon as a biliary colic, or sometimes as acute ureteric colic being mistaken as acute appendicitis. And there may be other conditions where mimicking that may be the other general conditions may become stone disease. So stone disease is one condition which we very commonly come across in our it's one of the more common differential diagnoses for acute abdominal general practice, general surgical practice. The second one is ureteric stricture. The ureteric strictures may be iatrogenic. So many times when there is a stone which is lodging somewhere here, that area of the ureter may be inflamed, edematous, and that might stenos. And more usage of laser these days can produce iatrogenic ureteric strictures also. We try to break the stones with the laser, and that laser can hit on the urothelium of the ureter, and that can produce a stricture. Especially that is very common with certain types of lasers. We use here a holmium laser, which has got lowest incidence of ureteric strictures, whereas the other lasers like thulium and all can produce more and more of ureteric strictures. So with increasing usage of lasers, these iatrogenic ureteric injuries and strictures are becoming more and more common these days. And inflammatory strictures and post radiation effect, all these can all produce obstructive uropathy related to pathology in the upper tract. Another entity called extrinsic compression of the ureters. There's another condition called retroperitoneal fibrosis. I'm sure all of you will be aware of what retroperitoneal fibrosis is. The third one is obstructive uropathy, an acquired one, where there is an obstruction at the level of below the level of bladder or below the level of bladder neck. That's the prostate and the urethra. As I mentioned earlier, BPH is one of the common conditions that we come across. BPH, benign prostatic enlargement, and the CA prostate, bladder neck obstruction, the urethral strictures that I was talking about, and the most important one is neurogenic bladder. What is the neurogenic bladder? The neurogenic bladder is one where the patient is not able to empty the bladder effectively, where there is a hypocontractility of the detrusor muscles because of some spinal pathology. Patients would have undergone some spinal fixation for a fracture of the spines, or there may be some sort of a meningomyelocele or some sort of a sacral abnormality where the nerves that come out, the S2, 3, 4 nerves which come out from the lumbar canal, that can get compressed, that can get damaged and produce some sort of a defective contraction of the bladder detrusor, because the S2, 3, 4 innervates the bladder detrusor. So when these nerves get damaged, there is a possibility that the bladder can get a little weak in contractility, and these patients present with a larger amount of residual urine, which we may think as a retention of urine. But if you carefully analyze these patients and evaluate them, we will identify that these patients have got underlying neurological abnormality, which we call as a detrusor underactivity, or the earlier terminology was a hypocontractile detrusor. So this is one condition which often gets overlooked. Patients, when they get an ultrasound done, these patients will have some sort of a lower abdominal discomfort with which the patient come to a general surgeon, and this general surgeon asks for an ultrasound where there is a 200 250 ml of residual urine being identified, and then they put the catheter and refer the patient to urology for a TURP, because these patients with age-related prostate enlargement also will be there. So that will be mistaken for a prostate enlargement causing retention of urine. But in strict terms, if you further evaluate them, you'll identify that the chronic retention of urine is not because of a prostatomegaly, but because of an underlying weakness of the bladder. The bladder is not able to push out or pump out all the urine effectively, and there is a considerable amount of residual urine inside the bladder, where a relief of obstruction in the form of a TURP, transurethral resection of the prostate gland, may not be helpful here, because if you relieve the obstruction also, only if the bladder is strong enough to push the urine out, the patient will be able to void. So that distinction the general surgeon itself should be able to make, because sometimes what happens is, in a busy urology practice, or when there is a cutthroat competition in some corporate hospitals where a patient is being referred for a TURP, the consultant urologist may not be available at that particular point. He will ask one of the junior physicians to see the patient, get the patient ready, get the patient mobilized to the OT. The next day morning only sometimes the patient will be seen by the consultant urologist. By the time the spinal anesthesia would have also been given. So you understand now what issues can arise. If you operate on such patients, what will happen after the procedure is being done, when the catheter is being removed, also the patient will not be able to what, the patient will ask you, the complaint with which I came to you for, the complaint is still persistent. And what is the point in undergoing surgery? If the patient is asking, then you'll have absolutely no words to reply. And especially in the court of law, if you have to answer like that without proper evaluation, if you have operated on a patient, no, you will have absolutely no valid ground to stay at all. So it's very important for you at the referral level itself to identify these conditions, so that if you know the distinction between differences between what a detrusor underactivity is and what an obstructive uropathy secondary to BPHs, then it will be easy for you to refer the patient accordingly. You can refer if you feel that the obstruction is due to prostate enlargement, and if you feel the obstructive uropathy is secondary to the retention of urine secondary to BPH, then you can always refer the patient for TURP. Or if you feel that the obstruction or the residual urine is secondary to detrusor or underactivity, then you should refer the patient not for a TURP but for further evaluation in the form of a urodynamic evaluation. So urodynamics will tell you whether this retention of urine is because of an obstruction or because of a hypocontractility of the detrusor muscle. So it's very important at your level, at the entry point. General surgeons usually at the entry point level. At the entry point level itself, if you are able to distinguish between the two conditions, it will be easy for you to give the maximum benefits to the patient. So it's very important for a general surgeon to know.